Hi, everybody. It looks like we're still waiting on Dr. Hayes and Dr. Johnson.
Okay. I was going to say, I'm impressed people showed up on time, 7 o'clock on a Tuesday. This is awesome.
Okay, we are all here, all 9 of our fabulous coaches. Thank you so much for joining on your Tuesday evening. My name is Sahabi. I am one of the Lead Free Ohio practice program managers, not a practice coach. I'm super excited to have this meeting with you today. We'll go ahead and just start with some quick introductions. If you just want to popcorn along, I will pass it off to Mark.
Hi, my name is Mark Driscoll. I've been emailing all of you a lot, so I'm sure you're used to my name. I'm one of the kind of program managers for the lead practice coaching program. I will pass it to Dr. Takur.
Hi, I'm Rupa. I'm a primary care pediatrician up in Cleveland. I'm happy to see some of my fellow Clevelanders on this call. And I'm medical director for the Lead Free Ohio program. How about Joel next?
Hello, good evening. I'm Joel Davidson, for those of you who I haven't had the chance to meet. I'm from Akron. I'm a general pediatrician and I run a lead clinic at Akron Children's. I've done some stuff with the electronic health record, which drew me into this space. Really, patients drew me into this space to begin with. Let's be honest. But yeah, that's me. And I'll go to Elizabeth.
Hi, good evening. Liz Dawson. I'm the Chief Operating Officer of the Ohio AAP. And I'll pass it to Dr. Peltier.
Hey, everybody. I'm Chris Peltier. I'm a general pediatrician in Cincinnati. But as Rupa knows, I was born and raised in Northeast Ohio. I'm a West Sider, Clevelander. And I am also have the honor of being the chapter president for the Ohio AAP. And I'm going to pass it over to Eva Johnson.
Hi, Ava Johnson. I'm a pediatrician at Rainbow, and I've worked on lead from when they first started the lead AAPQI and have done some work with our practices up here as well. And I'm going to pass it to my colleague, Natalie. Dr. Woods, sorry.
Natalie is fine. My name is Natalie Woods, and I'm a general pediatrician at Rainbow as well. Work with Ava and Rupa through our collaboration with Cleveland Clinic on lead. Oh, I'm supposed to pass it. I am going to pass it to, let's see, Iris.
Hi, I'm Iris Castillo. I'm a general pediatrician for the Nationwide Children's in Toledo group. So I'm from Toledo. Joel, I recognize you from Akron Children's. But yeah, I'm working in the Northwest Ohio region now. And so I missed the beginning part. Am I supposed to pass it on to who hasn't gone yet?
Iris, thanks for making that connection. I always recognize names, but I could not place it until you said why. And
yeah. So I will pass it on to, is it Shan Yin? Have you gone yet?
Hi, my name's Shan Yin. I'm a medical director of the Cincinnati Poison Center. We also cover the Cleveland area. I'm a pediatrician. I'm also a medical toxicologist in emergency medicine in Cincinnati Children's Hospital. And I will pass it to Dr. Hayes.
Hi, y'all hear me?
Yep.
Okay. My name is Hannah Hayes. I'm the medical director of the Poison Center in Central Ohio Poison Center. And I'm the chief of toxicology at Nationwide Children's, where we do the inpatient chelation for most of the Central Ohio area. I think that's everybody. Did everybody go? No?
You got one left.
Dr.
Jennifer, go ahead.
Hildeman, is that it? I
Yeah.
got it.
Hi, guys. I'm Jen Hilgeman. I'm from Dayton Children's, and I'm a general pediatrician. I got involved with the original Ohio AAP led QI project and happy to be involved some more.
Thank you all for introducing yourself. We have a really diverse group of locations, practice experience, years of practice. So I'm super excited for this group. I think it'll be a really valuable opportunity for all of our 55, right, Mark, practices enrolled in this program. This is the most the Ohio AAP has recruited. So we're really looking forward to this new, innovative, sort of QI, but not QI education model. So now we're going to hop right into administrative time. I'm going to share my screen with the couple of administrative things that we are going to cover today. So at 6:55 p.m., all of you should have received an email from me with your contract signed by our CEO, Melissa. If you could download that, sign it, and return it to me, that would be great. And then I'm going to drop this link in the chat here, hopefully. And this is a conflict of interest form that we have all of our speakers and presenters share or complete, excuse me. So if you could complete that, and while you're signing and completing these forms, if you have any changes to your schedule that you need to address with Mark, now would be a great time to do so. You can message him or say it out loud, whatever is preferred. And I'll give about 3 to 4 minutes to knock these things out if you guys can type fast enough. If we need more time to fill out the conflict of interest, that's totally fine.
Can I ask you, Suhavi? I just filled this out this morning for Project First Line. Do I need to do it again, or is that on file?
No, you do not. If you have filled one out in the last 2 years, you do not need to fill one out again. But if it's a year and 11 months, just go ahead and do it again, just to be safe.
I have a question. This is Hannah Hayes. Mark, we had a couple practices that had schedule conflicts with me, and I know you're working to reschedule some of those. Are there any that I'm waiting on to be added to my calendar?
I sent over a few. I was actually going to ask you tonight for the lower lights practices. So they should be sent to you, but I'm not sure if you've clicked accept or not.
Okay, I'll double check then. I thought I accepted everything you sent, but I must have.
And I'll go through again and double check as well.
Oh, no, I missed one. It's two.
And there's lower lights Franklinton on April 15th.
Yep, I just got that one. I did Union Star.
And Union Star. Yep, those are the 3.
Okay, thank you.
and I hate to pull focus. I have just a couple of questions for a couple of the coaches. Dr. Johnson, there was a practice that I gave your booking page that booked for this Friday, which was very soon. So I just wanted to make sure that you're okay to do this Friday, or if you wanted me to have them reschedule for a different.
That's where I work.
Oh, okay.
So I don't know if that's like, we do coach, like, it's where Natalie and I both work. I don't know if like they need a coach, like, I don't know how that really works because we both work there.
I'll default to Liz, maybe.
I think that's fine.
Okay.
Yes, I can meet with them Friday.
I will do that then. And
It helps
then,
for convenience too.
yeah. And then Dr. Woods, I know that you had sent over some dates that were conflicts. If you can just send me the list of the ones that I'll need to reschedule, or if you have them now, I can look at those.
You know what? There won't be many. I'm seeing what I can move around, Mark, so that I could keep at least the ones that are scheduled where they are.
Okay.
Is it possible I can get back to you tomorrow morning? Would that be okay?
Yeah, even if it's by the end of the week, it should be fine.
Okay, great.
Thank you.
Mark, did you have any more scheduling things to discuss?
No, I'm all good now.
Okay, are we all done with the conflict of interest form and are in the process of signing the contracts? Does anybody need more time? Okay, I will pass it over to Dr. Takor to share a little bit of lead prevention and just some general education pieces. I'm going to share my screen here, hopefully in presenter mode. So just give me 1 second. I'm hitting presenter mode, but I don't think you're seeing presenter mode. Are you seeing presenter mode now?
Yeah, we are now.
Yep.
Okay, perfect. Can you see the whole screen or do you happen to see your faces reflecting back to you?
Nope, we see it all. I mean, we
Okay.
see the whole screen.
Perfect. I swear the settings change on me. So just let me know when you're ready for me to advance the slides.
Sure, go ahead. All right, so some of you are experts in lead, some of you may not be. However, we are all here tonight because we are pediatricians and we know that lead is a ubiquitous contaminant. It is a neurotoxic metal that deposits from the blood into every tissue in the body and impairs basic cell functions that are common to all tissue types. So this is why we see lifelong consequences of childhood lead poisoning at even low levels of exposure. So the ultimate take-home message of our recruitment and our kickoff webinars was really that primary prevention is critical to our children's success and optimizing their outcomes. So our goal with this program, as well as the QI collaboratives that some of you have participated in the past with me, is really that no child is exposed to lead because there is no safe level of lead in the body, and because the effects of lead poisoning are not reversible. So therefore, we need to recognize common sources of lead contamination in our environment, in our homes, and implement preventive strategies to prevent exposure. So a lot of what we'll talk about is that primary prevention or anticipatory guidance that we give to parents, but also when we do screening, so that secondary prevention piece. When do we do screening? How do we make sure we're screening kids optimally? And how do we make sure we're doing good follow-up? Next slide, please. So preventive strategies include reducing the hazards that a child might be exposed to by eliminating the source of lead contamination itself, ensuring lead-safe housing, and if someone is renovating, ensuring that lead dust is properly contained and disposed of using lead-safe practices. So this involves getting a certified contractor, making sure that areas are tarped off and things like that. Since we can't completely eliminate lead in our environment a lot of the time, we also need to take measures to reduce lead exposure using good cleaning and hygiene practices. And then finally, we can reduce the body's absorption of lead by encouraging a good diet with adequate iron intake. In addition to that, vitamin C and calcium as well. We do have detailed slides on those pieces of anticipatory guidance that we've shared in our recruitment and kickoff webinars. I wasn't planning to go through a lot of that here since our practices have already received that. But if that's helpful to you to see, we can share those slides, or I can review them as we get towards the end, just for you to know, what education we hope that our practices will provide at the 6-month visit and on.
Hey, Rupa.
So,
Yeah,
yeah.
I'm fine if you don't go into detail, but being one of the people that probably is not a lead expert, if
Yeah.
you could just, if Marker could email me those, just so I have those for sort of reference when I'm presenting. Thank you.
Absolutely. So we have slides on like general hygiene, so washing your hands before you eat, those types of things, and leaving your shoes at the door. We have slides on occupational exposure. So if a parent works in a high-risk industry, and we have a list of what those are, things that they can do to minimize bringing lead home. And then we have lists of nutritional recommendations, including specifically what foods we should try to incorporate into the diet, but we can share all of that with you. Not a problem.
Can I ask you a question too? I'm sorry, again, being the one that probably has the least experience. I know at one of our, I think when you and Nick were presenting at one of our, maybe it was our spring, there were some questions about spices in the house. Do you have some information on that too? Because I remember sort of that conversation, and that was actually sort of new to me, and I learned a lot that day.
Absolutely. So we do know that families that import a lot of goods, so that could be spices and herbs, it could be ceremonial powders, it could be cosmetics, it could even be dishware and things like that. Lead contamination is very common in those products. And so when we do find that a child is lead poisoned and they do, home inspections and they look for sources of lead, those are commonly positive. So we try to counsel families to look for lead safe certified products when they're shopping. And so often spices and herbs will have some type of a label on them that says that they are free of contaminants. So that might be one thing we could counsel families around as well. But that's one of the pages in our board book as well.
Yeah, and if I may, I'm going to add just a little bit. And Chris, I'm not trying to intimidate your sentiment, but really one of my goals, and I think when practices enter into this discussion, I think that they're thinking about screening. I think that they're thinking about that secondary prevention. But it's kind of interesting. Like one of the goals that we have is that this becomes a bigger topic within these practices that we're working with. And really, we want families to start coming up and asking questions like, should my kid get tested? What should I avoid? How do I avoid that? And we may get to a point where we don't know, some of those answers, either through secondary prevention, kid gets exposed, tie, we don't know why. That doesn't mean that education isn't valuable to the family. They've all learned a lot, and trying to put kind of even that empowering message of like, this is just something that we need to learn about. And these are the common sources, and you do have some power and some control over that. In my mind, that's also that's where this project will take our practices, and not just into the screening. We want them to screen, we want to include screening, but it is really important that practices themselves become a little bit more versed on some of those nuances, and a little bit more comfortable talking about that in this day and age.
And to your point, a lot of the criticisms around the system as it is that we're waiting for kids to get lead poisoned and then going into the home and teaching families how to minimize further exposure. If we take the step of, at the 6-month or 9-month visit, trying to really educate families on this, we may prevent that lead poisoning from happening to begin with. So yeah, great conversation. Any other thoughts on this piece before we move on? All right, we'll move on to the next slide then. Okay, so we've talked a little bit about anticipatory guidance. Now let's talk a little bit about who we need to test. This that you're seeing on the screen right now is the Ohio Department of Health's questionnaire that identifies risk factors. So per Ohio law, we need to test kids under the age of 6 years if they are Medicaid eligible, live in a high-risk zip code, spend time in a home or building built before 1950, spend time in a home or building built before 1978 that has deteriorating paint or active renovation, if they have a sibling or playmate with lead poisoning, if an adult contact has occupational or hobby-related lead exposures, or if they live near an industry known to generate lead dust. So if the answer is yes or don't know to any of these questions, they will need a lead test. Next slide, please. So you notice that the first two questions on that were Medicaid or high-risk zip code. ODH does have a list of high-risk zip codes. Most of the zip codes, it feels like, in Ohio are on that list. But basically for those on Medicaid or who live in a high-risk zip code, by law in Ohio, we must order a lead level at 12 and 24 months. If they answer yes or don't know to any of the other questions, they should also get a lead test. So even if they're not on Medicaid, they don't live in a high-risk zip code, but they do have a parent who has an occupational exposure, they should get that lead test. If we see a child between 3 and 6 years of age who is on Medicaid or living in a high-risk zip code, but never had a lead level done before, we should order a lead level at least once. If in that age range, 3 to 6 years, you know, whether they're on Medicaid or in a high-risk zip code, whether they had a positive test in the past or not, if they have a yes or don't know to any of those other exposure risks, we probably should continue to test just because that indicates an ongoing exposure risk. Next slide, please.
Rupa, I don't know what you usually do for kids with a sibling with a elevated lead. I sort of have my cutoff around 8. I don't know if you have a cutoff or if there's one that people generally recommend. Like if they have like a 16-year-old sibling, I generally don't, I'm not testing those kids, but I don't know if other people have something they do differently.
That's a great question. So I don't know, Joel, if you have thoughts on this. I guess since we're only administering that questionnaire until 6, I think if I know that there's a child who's lead poisoned, I might go a little higher, 8 or 9 maybe. I don't know that there's a formal rule around that though. Joel, what do you think?
Yeah, I think the answer is 6 years old if you were like taking the test. In real life, I think it depends on how concerned the family is. So I think if you want to answer that for practices, it's really up to 6 because that's where we see like the most impact on developing brains with that toxic metal of lead. Up until that age, have I tested kids over 6 years old? Absolutely. Some of those are ones that I'm just even still following that are still high that I want to, kind of follow through with. In pregnant women count too. And that's another thing that's not really always in the guidelines, but if a mom is pregnant and we know that there's a child that has an elevated lead, I usually recommend to that mother that she find ability to get herself lead tested for her, pregnant baby.
I think too, like if you have concerns about delays or behavior issues or those types of things, I would have a lower threshold even for testing at older ages. So
yeah, I just like the kids that come in that have an elevated lead, then I say, who else lives at home? And I try to get other kids tested. And I sort of just, I'm thinking about, I usually don't test other siblings if I find an exposed kid over 8, but I don't know if like, again, if that was, I know it won't be like through the screening questionnaire, but just through like, once you identify. Yeah.
Yeah, and it's probably important to get an educational history on that older child, how they're doing in school. Are they having any difficulties? If they're in a similar environment or in the same environment, it's likely that even if their lead test was normal now, that they had some exposure earlier in life, and you can contextualize that in your advocacy related to the older child's education plan. So, that's what I have to think about the older kids. The other population that kind of gets a lot of press in the literature is like gunshot wounds because bullets have lead in them, and so some people will check that in those kinds of situations, and it'll be really high. And the difficulty is that there's not always a good level of evidence to talk about what to do with that teenage child that's now exposed to high amounts of lead. I don't know if anyone else on this, Paul, there's some good experts here, so chime in if you have other information. Go ahead, Chris.
I have a different question, so I'll wait to see, Joel, if anybody has any response to what you guys were talking about.
I think you can go, Chris.
So this is a sort of a nitpicky question, and I sort of and it's really more of an ODM kind of a CPC kids question. Do you know, and you may not know the answer to this, but when especially that 24-month-old, they're on Medicaid, is that they have to have their second lead by 24 months or at some point during their second year? Do you know like when it counts? I mean, obviously we're doing it, right? So but it's more to tick that box for like staying in compliance as a Medicaid provider. Do you know sort of when that has to be done? Is it by 24 months or is it, because typically we're not seeing kids till after their second birthday for that 2-year checkup. But I've always sort of been curious, and I've never really gotten a good answer from sort of our care source rep.
Joel, do you know this?
You were hoping I knew the answer. Chris, I feel like this is the same question that we ask about like updated vaccines by 15 months. It's like, come
Right.
on.
Is it right? Is it with 15 to 16 months? Okay, so good. I'm glad I'm not the only one that really doesn't know the answer to that. But okay.
It cannot be 24 months solid. Otherwise, it would be like so obvious in the data that we would be doing so poorly because so many people test again at the second year visit. And,
right.
and I actually recommend that that's where we do it for those high risk kids is at the 2-year, 24-month. And those are all after there's probably 3 or 4 a year, a month that are scheduled that week before. But Chris, I can take that back and we'll look at it. We'll get back about
Thanks,
that.
Phil.
Awesome. Other thoughts on this before I move on?
Rupa, I did want to add one thing. Zoom has gotten me like all discombobulated. I'm only looking at faces now. But I was going to say that it's really, really important, that second bullet, the catch-up percentage of kids that are positive that don't come in, it's a different population of kids. And, we'll find when we screen, somewhere between 2.5% and 5% of kids, that's like the definition of where the level has been set for what is an elevated blood lead level. And again, 3.5 was a reflection of that mathematical thing of overall we're reducing lead burden in our communities. That's good. And 2.5, 3.5 to 5 still does make a difference in a developing brain child. That's important that we have that message. But we will find, like probably up to 7.5, maybe even 10% of kids are like high lead levels for kids that we catch up in that never been tested category. And so, just kind of it's a really interesting phenomenon, but practitioners will find out like, if they're doing some catch up, they'll find more high lead in that population because those are the same population that are living in communities that have a high lead burden.
Absolutely. All right, we'll move on to the next slide, Suhavi. Okay, so once we've performed a lead test in our clinic, Ohio law mandates that lead levels be reported to the Ohio Department of Health. So all of our labs that we use in our healthcare systems are required to report to ODH. Levels greater than 3.5 will generate a call from the local health department to the family to administer that questionnaire assessing for lead exposure risks again. Levels greater than 5 also prompt an automatic referral to Help Me Grow for early intervention services. And levels greater than 10 should also result in a home inspection performed by the local health department, hopefully initiating the abatement or remediation process for that property.
All right, got another question. Sorry.
Of course, yeah, go for it.
I'm actually gonna probably pitch this to Shan since he's in my city. So Shan, so my private practice, what we do is we do the when we screen, if we have a kid that screens positive and we need to do a blood lead blood, we do the blood dot cards and we send to Cincinnati Children's and you all run the Cincinnati Children's runs those. Do those automatically then, if it's elevated, that automatically gets reported to ODH? Is that correct? I just want to verify that.
I honestly don't know the answer. I could certainly find out if children's specifically will report to ODH or not. I don't know.
Okay. my understanding, this could be wrong, so if you look into it and you find it's incorrect, let me know. But my understanding is any lab that runs a lead test is required to report it to ODH.
Perfect.
So
Okay.
whoever is running it.
Sounds good. Similar to like COVID, like when we were doing COVID. Okay, great. Thanks, Rupa.
Be real surprised if they weren't. Although this is an interesting exercise for practices to go through. It's like what you tell your kids, like find out where the food is sourced. Have them find out and just ask that question as a coach. Again, I'm getting a little ahead of myself, ourselves. But say that's an interesting question. Why don't you see if you can find out where that's sourced and who talks to who, and it's just a couple phone calls or a couple emails, but that actually gets people really thinking about like what happens in the system. It's not a perfect system. There's always opportunities for improvement, and that activity itself will inspire and motivate people to kind of think a little bit deeper about what's happening. Well, why did that happen? Like, how many of my patients I haven't heard like. I was kind of surprised that Help Me Grow got an automatic referral. Like, I didn't know that. That's great to know. But how does that work? Like, now I can start asking my patients, all right, did you get a call from Help Me Grow, and when? How did that call go? And practices could do something similar. So I think the hardest challenge in this workflow is that like from purple to orange or post orange, when families I feel often they feel stuck. They've identified this problem, they feel concerned. They've talked to you or they've talked to some practitioner about what to do, and they're just kind of like, how do I know where my lead is? And the answer is like, we don't. And here's all the potential sources, and you do your best, and we'll check again. And a lot of families are waiting to get to that like orange health department. There's just not enough resources to go around in the state to be able to address all of those kids and all those houses. So. I kind of remind people that this is a multi-billion dollar, hundreds of billion dollar problem in the United States around housing. And, we're not going to solve that, that big of a problem right away, but we're going to help people get to the right place to where they can live in a lead safe environment.
Absolutely. Okay, so next slide, Suhavi. All of the practices they've seen all of these slides before, but they've seen this slide. We spent some time on it during the kickoff. This slide goes through some different sample collection methods just to understand the pros and cons of each in case a practice thinks that maybe they need to switch up what they're doing. So we have, for example, a few different options for capillary testing, which have the convenience of being obtained while the patient is there in the exam room, but does have the drawbacks of requiring a venous sample for confirmatory testing if the result is over 3.5. And since we're often doing anemia screening at the same time, at least for those at the 12-month visit, you would need to either have a point of care hemoglobin test available, like a HemaQ, or you would need to send the child to the lab for that blood draw anyways. So thinking through the logistics of what this is like for the family and whether it makes sense to do capillary screening if you don't have a HemaQ, just kind of having that conversation and figuring out how you can address that. The most commonly used forms of capillary testing are listed here. The Lead Care 2 point of care device costs about $4,000 for the analyzer. Another, I think, $650 for the test kit, $500 for the label printer, $50 per pack of labels. So it's totaling around $5,200 just for startup costs at one practice. I think Suhavi had shared some other numbers in terms of additional costs that go into that. And ODH does need to register the device. There's a process in place to actually be able to use a lead care in your office. You can't just buy one off the internet and get started. So there's a process in place. Because of that piece of having the results reported to ODH. So that's why there's a process ODH needs to go through for that. The potential here is that you do have an immediate result to share with the family, but we know that the device has very frequent recalls for inaccuracy. There's a significant risk of falsely low results, so false negatives. So a lot of us feel like, what's the point of screening then if we can't trust the result? So for this reason, most systems won't use a lead care device. Other options though, one is using a microtainer. So this is a small tube that's prepped with stabilizers to prevent clotting, and it allows you to collect drops of blood from a finger prick. It costs about $50 for a 100 pack of microtainers and about $10 for a pack of lancets and band-aids. So it's more affordable for sure. The benefit here is that you don't need to reinvent a processing workflow if you already have a lab that runs venous samples. You can use the same lab equipment that they would use for those venous samples on that the microtainer specimen. Some of the drawbacks, though, are that it does need to be refrigerated. There's a process in place after you collect the blood sample. You have to invert it a certain number of times to shake up the sample a little bit. It does need, both for this and the filter paper, it needs to be collected in a certain way to prevent hemolysis. So it needs to be free-flowing blood. You can't smear it into the, like kind of try to scoop it into the microtainer or onto the filter paper. It needs to drop on. So the risk of getting lab samples that can't be run is there, which would require you then to redraw or recollect the sample. Filter paper, on the other option, is similar to how a newborn screen is done. I think what Chris was alluding to, that they're doing down in Cincinnati, Dayton area. MedTox and Tamarack are independent labs that provide test kits, I'm told, at no charge. So you would mail those collected samples back to them for processing, or some practices have it set up where they have a centralized area where those tests are run, and then neighboring practices will mail those in. So I know that a practice that has recently joined the Cleveland Clinic in the Medina Talmadge area, Akron Talmadge area, was sending theirs to Nationwide. So I know that those affiliations exist as well for private practices. One of the benefits here is that those samples are stable at room temperature for 6 months. So you can collect a bunch of them and then mail them off, at the end of the day. You don't have to do any special type of storage for them. And in areas, especially rural areas where, that courier may only be able to take labs to a centralized location once a week or something like that, you have that stability as well to be able to do that. So if we're thinking about like Appalachian, Ohio or something like that, it's an option. The difficulty here is that the processing, you do have to either acquire a relationship or a partnership with an outside lab, or if you're trying to do this internally, it does require quite a bit of stakeholder buy-in to acquire new equipment to run those filter paper samples, training your personnel in the lab to run those samples, as well as training your nursing staff or providers in the office to collect those samples. So there is a bit of an investment there if you do decide to make the switch to filter paper. And then finally, we have venous samples. These are accurate. They do allow a hemoglobin to be run on the same sample. It is an attractive option for parents who want to minimize the number of pokes that their child receives, because it's just that one poke for both tests. And because you're doing a venous sample from the start, there's no need for confirmatory testing. The drawbacks here, though, are that blood draws are often not well tolerated by the patient. Families may find a trip to the lab to be a burden. They may go once and they were unable to get the lab, and then they're like, I'm never going back again. So often it just doesn't happen, and we see that testing isn't completed. So clearly here we have a lot of options when it comes to obtaining those lead tests, and each practice will need to choose their method according to the specifics of their practice and patient population, and what barriers specifically they're seeing, what resources they have access to, what makes the most sense for them. Any thoughts here?
I'll just say from our practice, so we used to do right, so we would screen on paper, and like if you had Medicaid or you lived in a high risk zip code, we'd be like, you have to go to children's. Now we have a children's lab 5 minutes from our practice, but our completion rate sucked. So that was when we decided we needed to do something. And we looked into lead care too, and obviously, the cost was a little prohibitive for us, and so we were very lucky to partner. So, Cincinnati Children's, as I put in the chat, Cincinnati Children's provides us with the filter papers, and then we just have a courier that picks them up, and that has worked really, really well for us.
How
So,
often
Chris, are you
does the
doing-
courier pick them up? Oh, sorry. Do you know how often the courier picks up those labs?
Every day, once
Daily.
a day.
Okay. Okay,
No, we
great.
just call them and say, hey, we have a pickup, and they come every day. So, yep.
And Chris, are you doing the HemaQ and then the filter paper?
So yeah, so we do a point of care hemoglobin, and then we do the filter paper that we send to Children's. Yep.
I think that's what like Cleveland Clinic, you guys are moving to that, and then Metro is doing that, and we are piloting at some practices here at Rainbow too. So seems like a trendy thing in the state to do it.
And it was great because it didn't cost us, it was interesting, we were looking at the time that was at the same time we were looking at lead, we're also looking at point of care like lipids, and for some reason, the lipids it was a little easier for us to do. The lead was just, those prices are a little pricey for private practice, and we're like, yeah, we're not going to do that. So it's been a really good partnership, and our when we look at our CPC kids and our care source, our numbers, they've improved dramatically since we've been able to do that.
Rupa, can you comment on the accuracy of the filter paper versus venous? Are they about the same?
In terms of, so yes, the result itself is the same. Any capillary method, though, there is a risk of falsely elevated results, which is why we need the confirmatory venous testing. However, in talking to Nick Newman, the reason for that is because a child may have lead residue on their finger that we're capturing when we do the finger prick, but it's not in their blood. His point, though, is if they have it on their fingers, that means they're exposed to it somewhere. And that probably does warrant some conversation with the parent around where there might be lead. Thankfully, their child hasn't ingested it yet if the venous comes back normal, but that's where the discrepancy is. So there is that chance of falsely elevated, but lower risk, much lower risk of the falsely negative ones. So it's a better screening tool. Especially if you think about like what do we want in a screening tool? We want it to be very sensitive, right? So we want to make sure that we're getting all the positives. And then we can do the follow-up to make sure that we are filtering out the false positives. So capillary tests at least give us that. Filter paper and the microtainer give us that.
So I am not at all a lead expert.
Okay, so let's,
I did want to just share a little bit more background on the lead care 2 machine and ODH's process. Just really briefly, we've assisted some practices that are interested in getting this lead care machine to try to help them to build out a little bit of a more sustainable model. So the lead care 2 machine, in addition to the costs listed on the screen, it also requires a $300 a year clinical laboratory program authorization. And then every person who's going to be using the machine or in some way involved in its care also has to go through a proficiency program, which ODH provides. There are about 140 of these machines in the state in use right now, which that specific number tells me that ODH is keeping a very close watch on those who are using this machine. And just in general, ODH does know that all the labs that are running lead tests are reporting directly to them. It's part of their process that I'm not super familiar with yet, but I can confirm that they are getting the reports directly from the labs. So just a little bit more information as you share all of these testing options.
Thank you.
The other thing that I would add here is it doesn't end at the screening test. It's like, what do you do with that afterwards? So what is your plan? And it's pretty obvious, like a lot of people probably know where to send people that have like that need venous confirmation, but it's actually worth asking them. Like, so where would you send your patient? Like, are they able to get there? What do you think about that process? What are you going to do? Like, what are you going to do with those positives? How are you going to talk about it? That's really, really important. Is that going to be like, is the nurse going to call? Are they going to get more information? Are you going to have a provider? Are you going to set up a visit? Are you going to set up a virtual visit now? There's a lot of options that we haven't even had even in the past to think through what happens after this. There are certainly situations where we even get really falsely positive capillary and venous tests. And so what are you going to do when you get a 50? What are you going to do when you have a 70 or an 80? What's that process look like? How's that different than, you know, your 7.5?
Yeah, definitely. So on our next slide, I think we do have some of those best practices. So we'll kind of go through these here. So this slide might be a good reference for you. We also have a best practice sheet that we've developed that you can kind of go through as you're talking with your practices. But when we're thinking about how to guide the practices that we'll be meeting with on improving their own clinical workflows, it's important to keep these ones in mind. So we should be providing anticipatory guidance starting at the 6-month well visit. We should be administering the ODH screening questionnaire at the 12-month visit. And if the patient is on Medicaid or lives in a high-risk zip code, so those first 2 questions, or answers yes or don't know to any of the other questions, then we need to order a lead test. If we ordered a capillary test and it comes back elevated, over 3.5, we need to confirm that abnormal result with a venous test. And those same guidelines apply to the 24-month visit. And if the child is older, as we mentioned before, 3 to 6 years, and have never had a previous lead level done, but are on Medicaid or in a high-risk zip code, they should be tested at least once. And if they answer yes or don't know to those questions on the questionnaire, you can continue to test them yearly. If again, in that age group, it comes back above 3.5, we need to have a follow-up workflow in terms of getting the venous confirmatory test done. Next slide, please. So I realize that this is a lot, but we do have some resources to make it a little bit easier. Practices can use our board book and rack cards to facilitate their conversations around anticipatory guidance. They've gotten a little bit of training on how to do that in our recruitment and kickoff webinars already. They could also use our appointment reminder and education cards to really drive home the need for testing at 12 and 24 months if they have a family that might be a little bit hesitant to complete that testing. If a practice would like to explore the option of changing up their testing method, maybe switching to filter paper, for example, they can identify folks in their internal lab, like we did at the Cleveland Clinic, or external labs like MedTox and Tamarack, or one of the other, larger healthcare organizations in the area who might be able to run those samples for them. And in doing so, identifying ways that a practice can conduct lead and anemia screening together rather than sending to the lab for one and conducting a finger prick for the other, that can be really helpful just in terms of patient satisfaction and minimizing pokes, minimizing trauma to the patient, and making sure that those labs actually get done. Because we know that once we poke them for vaccines and that hemoglobin in the office, the chances of them going to the lab to get that next test done are pretty low. Practices can also integrate the ODH questionnaire into their EMR pre-visit surveys if that's something that they do. If it's not, it's something they could consider doing. Thinking about just ways to take the burden off of the office staff at the time of the visit when there's already so many other things that need to get done. So just a few resources we can offer. So before we show you the best practice list and some of the other tools that will give you for your practice sessions, I just wanted to touch base a little bit on coaching. So Sahavi, you could go to the next slide if you'd like. So many folks think of coaching as synonymous with mentoring, or a lot of people have a really negative reaction to it because they have experience with it as a punitive intervention for those who are struggling or not quite meeting benchmarks or whatever it might be. So while mentors can coach, and coaching can be used in performance improvement plans, coaching can really be used by anyone, anytime, anywhere, with the intent of performance improvement or career enhancement. Mentorship typically involves identifying someone with expertise in your field, asking them questions, and having them tell you what to do based on their lived experience as a content expert. Mentorship, therefore, is pretty directive or prescriptive. Someone's telling you what to do. Coaching, on the other hand, is participatory. The coach isn't an expert in anything but asking questions, which is why I kind of started this saying, you don't need to be an expert in lead. We're going to tell you some of the basics of what, your conversations with these practices might include, but you don't need to be an expert in lead. The coach just asks questions. Both members of the coaching relationships participate in moving the coachee forward. So it's a participatory style. Mentoring can be long-term and informal, whereas coaching is typically a short-term formal relationship with a specific performance goal in mind and continues until that goal is met. A mentor tells, whereas a coach asks. A mentor is a content expert. The coachee is the expert in themselves. A mentor gives answers. A coachee, I should say, generates their own answers in response to the coach's probing questions based on their own knowledge of themselves and their practice and their patients. So it's really a very different model. And that's why, I wanted to just spend a moment going through some tools and going through that lead action plan with you. So next slide, please, Suhabi. The tools a coach might use would be asking those questions. So Joel listed a bunch of them as we went through the past couple of slides. Questions you could ask just to get them thinking about what their processes are and how things work and how things could improve. The goal is really to listen to understand, not to respond and tell them what to do. So a great way to keep yourself in that listening to understand space is reflecting and paraphrasing and summarizing to shine light on what the coachee has just shared with you. So examples might be, I hear you saying that work-life balance is really important to you, and you want to maintain this for your team above all else. Or it sounds like you're worried about what effect this new workflow will have on your nursing staff. Do I have that right? Or something like, I'm hearing that efficiency is something you really value. Is that right? Is that correct? Do I have that right? So really trying to focus them based on what you're hearing them say, focus them in the direction that seems to be most valuable, most in line, will have the most meaningful impact on them and their team. And then you can follow up with questions that might kind of take them a little bit further. So what do you think is important to your team as opposed to you? How do you think they would respond if you shared this? Or how do you think they would respond if you asked them to do this? What does your ideal state look like? What would get you one step closer to that ideal state? So at this point, I'll ask Suhabi to pull up that lead action plan or our coaching worksheet, just to show you what those pieces look like built into the tools that you'll be able to take to your practice session with you. And then Joel and I can do a little role play.
Just 1 second.
Sure. Okay, so this is a sheet that you'll be able to take with you to your practice sessions. And it's just a list of questions to kind of take them down the path of identifying where they're at, where their baseline is, what they want to work on, and what next steps might look like. So you don't have to use this verbatim, but it's at least a guiding outline. So the first question here is, what is your current workflow? What is your ideal workflow? What's your greatest barrier? Then what is one specific step that you could make to get you one step closer to that ideal, essentially? And then once you've identified that step, how do we make that happen? So who needs to be involved in that ideal workflow? Whose buy-in do you need? Who's actually going to be doing the work? Who do you need to talk to? What testing materials or documentation tools are needed to make your ideal a reality? And then what can we do to help support you as the Ohio AAP? And then in planning your action steps, once you've kind of figured out the logistics, what will you do in 1 week, in 1 month, in 3 months, in 6 months? And if it's helpful for the practice to kind of look at a swim lane diagram. So as, I don't know if you've seen swim lane diagrams before, but essentially in each of these horizontal lanes, on the side, like where there's provider, you could put your MA, you could put your RN, you could put your front desk staff, you could put, if you have a social worker, community health worker, whoever that might be. And then kind of go through the process. So where you identify that patient, whether it's you're working on anticipatory guidance or on improving screening or on improving follow-up, who's the first person that comes into contact with that patient? What are they doing? How are they passing off to the next people? What are each person's roles and responsibilities? So if it's helpful, I can send out an example of what a swim lane looks like for other projects that I've done, just to kind of see what a practice could do. But sometimes it's nice to visualize who's doing what in what order, and where how many handoffs a patient has, who's really the most knowledgeable about that specific issue, who's in the best position to spend time with the patient in that moment, kind of figuring out what works best for your practice. And every single practice's swim lane will look different. Everyone's action plan will look different. Their action steps will look different. So this is really a way to customize their next steps based on, again, what their goals are, what they're hoping to do. I have received a few questions from some of the practices up in the Cleveland area around who should be attending the practice sessions. I have told them, and Suhavi and Mark, you can correct me if I'm wrong. Basically, I want at least the person who has enrolled. If they're able to get additional members of the team, awesome. Because as you go through those questions, the more input you get from different members of the team can be really helpful. So for example, I'll tell you, when we went through the Lead QI Collaborative a few years ago, what we learned was that providers were like, yeah, okay, I understand why we need to do lead, but I don't understand why my MA is not doing it. And then the MA was like, well, I try to do it, but then the provider tells me that I'm running behind and I'm taking too much time, and they're yelling at me to get out of the room because they want to go in and do their part. So I don't have time to do it. So I have to pick and choose what I'm doing, and I just choose not to talk about lead. So, kind of figuring out different people's perspectives on what's happening and identifying, getting to the root cause of really what the barriers are can be really helpful. So as you're talking to these practices, if you're able to get different points of view, awesome. If not, at least working with that, lead champion in that practice to kind of think through this is at least a starting point. So I'll stop there and ask if there are any questions or thoughts.
I can just share real quick to your point, Dr. Thakur. From talking on the pre-surveys, a lot of the practices have asked if they can include other members, or have said we're going to have our MAs or our nurses attend. So I think in a lot of the visits, you'll see more than just the provider.
Which is awesome. Because it's not always easy to get people to stop what they're doing to take time for thinking like this. So that's awesome.
Yeah, Rupa, I would share another kind of thing that came up even in our organization recently was the providers learned that the medical assistants were actually saying certain things about lead, and they were actually not as knowledgeable about lead as they wanted them to be. And so the providers recognized something like, oh, I didn't realize that you were even talking about that when you were ruining the patient, or let me help you understand a little bit more about this issue so that when you do talk about it, that it's the right information. And so I love this activity because I think it actually opens it up, and people are like, well, no, let me tell you about what I do in the workflow. And sometimes it surprises us all that, like, wow, I didn't realize that person was passionate about, interested, or in that topic. And we'll try to keep it on to lead, but. I also recognize that we're probably, like, as you're putting up the slide on mentoring and coaching, I think we're in medicine very like mentor centric. So forgive us. We're just used to doing it this way. We're trying to move into more of a coaching model, but we recognize that, like, even today, we're like talking to you about what we've created and showing it to you so that you can then distribute that. But hopefully this becomes a coaching discussion when you're out at practices, and practices may not expect that. I think that's another kind of thing that I'm starting to realize as we get some of these invites, kind of started to be scheduled. People are asking questions like, well, should I be there? Why should I bring my whole team if you're just going to tell me about who I need to screen for lead? And that's not really the purpose of these training sessions. It's really to have people think about what's going on in their practice, identify some area of improvement, and some opportunities that they are able to pull out of their own practice. And your job as trainers is to facilitate that discussion, just like it would be any other topic. And feel free to say, I don't know, why don't you look it up and find out?
Yeah, exactly. You're not expected to be the expert. If you have an answer, awesome. If you don't, it is very much okay to assign that as something that they do. I wondered, Suhavi, if you could bring up that best practice sheet too. We can just go over that, and I think that's a really helpful resource.
I have a quick question while she's bringing that up, if you guys
Sure.
don't mind. Will we get kind of like a comprehensive list of what the practices have already received, just so that for our awareness?
Yeah, do you want to, Suhavi or Mark, could you send out the recruitment webinar recording and slides as well as the kickoff?
That would be perfect. Thank you.
Yeah, and there, may be some practices that haven't gone through that recruitment, like that initial online module yet, that online discussion. There is another one of those coming up on March 7th. So Rupa did the first one. There was how many practices, Suhavi or Mark, that were involved in that one?
Probably 20 or 25, about half and half.
Okay, so we'll have the other remaining half kind of participating in that first introductory kickoff discussion. That's virtual, presentation style, going over kind of the content and exactly what we're talking about. That will help orient a lot of people. I'm sure that will help orient the group that I'm thinking of that was reaching out to me this week. And they really should be, after that presentation, ready to kind of participate in this more interactive coaching session hour. And really the hour, recognizing this model, the hour is really just a beginning of that relationship with that practice. And they should have questions following that. They should have questions a week later. They should at some point feel like frustrated or kind of up against something that they've encountered. So I fully expect that, and that's what growth looks like. So.
Okay, so I just wanted to share, we did develop this. I don't know if it's as small for you guys as it is for me, or maybe my eyes are just getting old, but thank you. So we tried to kind of list out some of the best practices that we talked about here today. And then in the second column, some intervention strategies. So for providing anticipatory guidance, educating the providers in your practice or the nursing staff, whoever it is that's going to be talking to families might be your first step. Adding some type of prompt in your EMR note, your documentation tools, having those rack cards or books to hand out. And then in your third column, you have resources. So as you go down the list of best practices that we're recommending, you do have different resources there. I don't know that we really did a lot in this specifically about follow-up, just because the systems in place for following up to elevated lead levels might be very different based on where you're practicing. But I think that that might be something, if there's interest, we can try to build out that piece as well. But that might be something that practices can think about a little bit more individually. Hopefully this is helpful.
Rupa, do you have any data on the county by county, like lead positivity rates? Like some of the counties I'm coaching, I don't know anything about those counties besides like where they are on a map. And I think sometimes that can be convincing to sort of say, like, this is your positivity rate, just to sort of convince people this is still important. I know like nationally the 3.5 is set by the bell curve, but is there any kind of data we could get for that?
So Javier, Mark, I know that we've looked at that in the past. Is that something we could send out with our coaching materials for each practice?
That would probably be a larger question to ODH. Just to be truthful, I'm not sure the timeline on getting some of that data back, but I will email them first thing tomorrow and see what we can get for you guys and the county level data.
Here, let's look at it real quick. I would how do you think you could engage with practices when they bring that question up in your training session?
Well, I know that like when we've tried to do universal testing through Rainbow, people say, well, our county, we don't have lead, is not an issue in this county because all our houses are new, and so that's not true. So, but for me to saying that's not true, like doesn't get me very far. I'd like to have some data to like say, actually, in this county, it's, 3% positive. You know what I mean? Just to give something more than just, we know lead is in every county in Ohio, but I think it just helps for those providers who are much more resistant to maybe like we're trying to move to universal testing. I think some people are more convinced with data. Some people aren't, but some people are. So
what I hear you saying is like that sometimes people want hard factual data that you're not sure where that exists. Does anybody have any like ideas about how Eva or the group, how you would approach that if you got that question in your training?
I
I
just have
see
a
what you're
comment.
doing, Joel.
It's actually kind of hard.
I
Because
have a comment, but I don't know if this is the right answer. I don't know, maybe a third of the kids I chelate are not from leaded paint. So I would probably say that. That's more telling somebody something, but it's the truth. It's spices, indoor candy, imported candies, old toys. I don't know if you want us to just say that, but for those of you who haven't chelated someone, you could just say that I said that.
Joel, you might be trying to get me to say like, why don't you look that up yourself? Some providers, they would probably be like, it was nice knowing you. Bye for this lead program.
Yeah, that's actually what I'm trying to get you to say. Or I just want you to facilitate that discussion. Like, just frankly say, I'm not sure. Let's figure it out. And what we've done is just go and maybe we do need to email the ODH, or maybe we do need to look on the ODH website and explore around. Like, I was trying to get like ask some questions, listen to what their concern is. Okay, well, tell me why you're concerned about like what might be hard. Why are you kicking me out now? When I think that the point is, if you ask the question and kind of set up an exploratory discussion, that puts the onus on them. We are not here to give people lead answers necessarily. We want them to improve the way that they interact with patients related to lead. We're sharing in that goal with them. Might even ask like what got you interested in in this problem in the first place? Like, what's your motivation behind doing this work together? Is that question helpful to your motivation? Do we really need to know the answer to that question, and why? Tell me about what you're feeling. Well, and you might hear a provider say something like, but all of my patients live in brand new homes. And you say, well, like, how would we like identify that? What is the standard like for universal screening? Like, is there a definition? There is. But it's not too far away from a quick internet search. And Eva, that's what I was saying. I think medicine is kind of still in a very mentory, like, you're the expert, tell me about it so I can get on with my day and I can just tell my patients this like one or two things. Like, not that easy. We're not talking about that kind of a problem. I've grappled with this. This is a very difficult question around universal screening. And Liz has challenged us to try to come up with what is our statement, what is our stance as the Ohio AAP around this concept of universal screening. And you might just say, well, what are your talking points? Like, how would you talk to families about that? Like, what would you say if a family says that they don't want it? Like, walk me through that.
I have a follow-up question about that because I was sort of afraid, worried, thinking that this, like, sometimes when I go into my pediatrician, it does like venture into like a Q&A session. And I don't blame them at all, because if I'm in a room with someone that has a different set of expertise than me, I do the same thing. Oh, while you're here, da, 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 da. So are we supposed to kind of avoid? I mean, I'm wondering, am I going to get a lot of questions about severe lead poisoning or chelation or next steps, or like steer the question away from that? Like, what would be your recommendation?
I think so. You can, if you feel like you know the answer and it would be helpful, you can give it. If you don't feel like you know the answer, then just say, first of all, Joel and I both have office hours once a month. So if there are questions that pop up, those can be shunted back to us and we can answer them. You will have access to, you can email me, text me, call me, whatever as well. So I can answer some of those questions. But some of it might be, okay, well, where would you look to find that answer? Who would you ask to find that answer? You can put it back on them to figure that piece out as well. And just be honest, I don't really know, but where do you think we could find that? And so it doesn't have to feel like a Q&A. Because some of it will be facilitating, right? Especially if you have multiple people in the room. It's like, okay, well, this person is saying this, I'm hearing this. What do you think of that? What can we all agree on? So it won't just be you firing questions at them if that's what you're worried about.
Well, I'm not, I just don't want to be telling,
Yeah.
because then they may not be all that useful. So I guess a good balance of, I thought what I was hearing is to more be leading them and telling them to look that up. Do you want me to do that even if we know, or I'm going to feel awkward telling somebody to look something up. Maybe I'm the only one. I feel like that's going to turn somebody off.
I think if you know the answer, you can answer it. If you don't know the answer, because I guess that's what I'm getting at is I don't expect all of you to be lead experts if you're not. If you are, awesome, added bonus. If you're not, you have an out.
And this doesn't, I have an out because I am not a lead expert, right? I'm a general pediatrician expert. So this kind of fits my, I can come in from the approach of, screening and kind of what we did and talking about that. And I'll, when they ask me a question, I'll be like, I don't know. We can find out, we can talk to, the Cincinnati Children's Lead Clinic. You're in a little bit different position because you are more of an expert. And I think, as Rupa said, I think it would be okay to share your knowledge. So it just kind of depends on, I think, the questions they ask and sort of your perspective. Because I'll be honest, some of the things that I have no clue, right? And I'm not going to be able to answer those. I can talk much more about flow and how it affects the office, and I'm very comfortable doing that. I'm very comfortable.
Or I'm not.
Things saying, here's where I can look. But I think if you know the answer, Hannah, I think it would be okay to definitely talk about that.
Okay. Well, because same to you, the flow questions and some of the general peds things, I'm not going to know. So it's good to know that you have office hours because I'm going to flail there.
And that's part of it. So I think when I'm thinking about coaching, it's not so much the technical, like what are the guidelines if this, right? Like that's something we can look up. We can help a practice through that. That's no big deal. It's more I think that identifying what they want to work on, identifying how they want to solve that problem needs to come from them. So me as a lead expert, I'm not going to go to a practice and say, I think you need to do this. And I think this is how you're going to do it. Tell you why, because it's probably not going to, because I have no idea what their situation is. So the coaching in my mind is more about generating their action steps. But if they have, nitty gritty questions about what something means or what the guidelines are, you can answer those if you know them. If you don't, you have backup.
Would it be okay, Rupa, to kind of lead with that, like as you begin like the coaching session, like, I'm here as a coach. These are our goals for today. To coach you through it and to work through it for your individual practice. We might not have all the answers to lead, but we can get those answers for you. But our goal for this session is to do this, and this, just to set that tone for this session, to kind of maybe alleviate some of that anxiety and just let them know what it's going to be.
Absolutely. No, and they've heard some of that before, because in our recruitment and kickoff webinars, when we were setting up what the coaching session would look like, I tried to make that clear. But I think setting that expectation, because of course probably only one person from each practice attended either of those webinars. So if we have a bigger group, setting that stage, I think, is a great idea.
Eva, I'm going to put it in the chat. I'm not leaving you hanging, I promise. The ODH does keep track of this stuff pretty well, and they have a pretty good website. Like Ohio Department of Health led has their own independent resources, and one of those is in that data section, and you can get a county by county breakdown of elevated lead levels from 2022 data, and it's kind of like a choose your own adventure. Find your county. You can filter. It's a good starting point for people that are interested in some of the really nitty gritty data. Housing stock is a bit of a different, harder question to answer, and people may have to kind of be creative at using what's out there, because I don't really have a great way. And when answering that question, it's really hard, especially for bigger systems that have expanding geographics. What do you include in that? So I'm going to include the link here, see if we can get you there.
All right, I know we only have 15 minutes left, so I'm Suhavi, if you want to go through the remainder of our slides on some of the specifics of the program, and then we can circle back if we have time for our little skit.
Okay, so I'm gonna go ahead and just share my whole screen here. I have a number of tabs up, so please just bear with me as I swap back and forth. So we really wanted to go through kind of the tools that you'll have in your toolbox when you're going out and doing these practices, that the practice coaching sessions that we have prepared for you. So our data points that we're collecting, we're doing a pre-survey, which Mark is doing on the phone with the practices. They set a goal for their time in the program during the kickoff goal setting. During the kickoff, they will be collecting baseline data. They'll be completing the lead action plan. There's also a trainer feedback form that the practices will participate in, and the reflection form is for the trainers to self-reflect. And then we'll be doing midpoint and endpoint data, and then a post survey and an exit interview. So there's kind of a lot of moving pieces here that you might not be seeing when you're in the office with these practices, but we did want to run through them so just a generic overview of the program. And then we do have a few resources as well: our childhood lead prevention toolkit, the physician resource guide, the family RAC card, our board book, Thanks for Keeping Me Lead Free, our appointment reminder and education card, and our best practices / intervention sheet. So I'm going to try to go through these quickly but clearly. So starting off with our pre-survey, this is just to assess confidence, knowledge, the routine and comfortability of the provider with screening, testing, and follow-up. And we're also going to get a little bit of information about their perceived barriers. And then just a note at the bottom of all of these, I added the responsible party, so you know what you're responsible for and what you're not. With Mark doing these on the phone, we are responsible for these. And you can find the pre-survey data for each of the practices you are coaching in a folder that I will share with you after this meeting. And feel free to interrupt me at any point with questions. Next, we're going to talk about the kickoff goal setting. So they're answering 3 questions during the kickoff call: what they're doing well, where they can improve, and their overall goals for the program. And it comes back to them as a letter, kind of like an intent to change. And since they're filling this out during the call, we are responsible, the Ohio AAP is responsible for getting these results or responses out to people. Next is our baseline data. This is a little bit of a work in progress, as we're having 50 practices complete this form, and we're getting some feedback about how to make the questions clearer. But in general, we are looking for the patient population under 24 months, the patient visits under 24 months during each data cycle, the patients screened using the ODH questionnaire, the patients with the screen that indicates they need a test, the patients with a test ordered, and the patients with a new test result in their chart, as well as barriers and issues with patients completing their ordered lead tests, and then practice demographics. The data cycles, so baseline happens in January, so we're looking at old data from January 2024. Midpoint will be collected in May, and endpoint will be collected in August. And we're responsible for this. We will ensure that you have all the pieces that you need before you get to your coaching sessions. That way you know kind of where they're at and where they need to improve. So just a note about that folder that I said that I would share with you after our meeting today. This is what the sample practice data will look like when it comes back to you. In that folder, all of your names are in a larger folder, and then there's the practices that you're assigned to. And then you can click on that, and their pre-survey download of a PDF of their responses, excuse me, will be in there for you to review. And then there'll also be this practice data. So this is just the questions that they answered, and then just some very simple calculations looking at the percent that they screened over patients seen, percent of the test ordered, percent tested, and then same for their patient population. And then there's a little column for notes where if they weren't able to report on that data, be it that they universally test or that they don't have the ability to capture this in their EMR, it will explain that in this table. I'm going to pause here for questions. Okay. Any questions? Okay. The next thing is the lead action plan, which Dr. Decor went over already. So if you have any more questions about that, please feel free to email. The goal with the lead action plan is in order to provide credit to the practices for participating in this program, if you could follow along with your own lead action plan and take notes on kind of where the practice lands on some of those pieces, especially looking at their goals that they want to set for the 1 week, 1 month, 3 months, 6 months, and then just send a picture of it to myself or Mark. That way we can document that we have the results back. It's just the way that we've decided to award credit for the program. And then, oops. The trainer feedback form is a very brief form for the practices to complete. It's just an opportunity for them to reflect on how the session went and provide them an opportunity to request more copies of our resources, which we're always trying to get in the hands of the provider and the patient. And then the practice is responsible for this, but we will remind them. And then there's also our trainer reflection form, which if I remember correctly, it's just 3 brief questions asking for what you used during the session, if you need more copies for your little binders that we're sending, and then a self-reflection on the training and providing feedback. And then in case you had a situation, which we don't anticipate happening, where you felt the training did not go very well, or you left the practice left with more questions than they had in the beginning, there is an opportunity to click a box that says, I would like the Ohio AAP to call me about this training. So if you get super intense questions, feel free to check that box and we will call you. And then Dr. Chakor or Dr. Davidson will help bridge whatever gap is needed to make sure that that practice left feeling really good and confident. Obviously, we don't anticipate that happening, but I did want to let you know that there are a couple of safeguards in place. And then our midpoint data, we're looking at some of the same things as the baseline, just with a few things removed. The practice is responsible for this, with obviously plenty of reminders from us. And then endpoint looks at the exact same things as the baseline. I will pause again for questions because I know that I just flew through that.
So Suhavi, just kind of based on what you just went over, so is really the main sort of goal, product, endpoint of the coaching session to do that action plan? Are you going to sort of provide us with an agenda of things to make sure we go over? Because obviously they've had sort of a training session already. So just kind of sort of what are sort of in that, it's an hour, right? Sort of what really are we hoping to accomplish in that hour? Obviously, it sounds like that the sort of lead action plan is probably the biggest ask, but just kind of sort of what other things are we sort of going over with the practices during that hour?
That's a great question. Let me pause my screen sharing here and show you this and turn off my camera blur. Just one moment. Okay, this here is a trainer binder, and you will all be receiving one of these in the mail, hopefully by the end of this week. We're waiting on one more thing from our printer. And so in this binder, you have a table of contents with what else inside of it. You have contact information for myself and all the other program leadership, including Dr. Davidson, and Dr. Takor's cell phone numbers. And then we have a QR code sheet that the practices will also have. And you can start by just going over some of these resources. We have our recruitment webinar slide deck, the kickoff slide deck, our toolkit, the physician resource guide, and our family resource page. It just, we weren't sure if they were going to want to open up everything at once, so we didn't print them out. But these are also found on our LED Hub page that I will navigate to in a moment. And then you can also show them a sample of the RAC card. You'll have one copy, and they will also have one copy in their folder. We're working to get the new RAC card approved from ODH, but there's just some delays going on there. So we're actually going to distribute to the practices the new RAC card once we have it approved. So this is just for them to see and for you to show how they would use this in their office visits. It's just a family card with the basic information about lead. And then if you need to reference the train the trainer slides, they are also printed out here. And then the pre-survey data form that we just went over, the data collection form, and then the big piece is that lead action plan. So you are going to use the lead action plan in conjunction with this best practices sheet to help them determine what their next steps are going to be and help them set goals. That's where the large part of this conversation will be spent. And then we also have, just as a final wrap up of this binder, this is a lead appointment and education reminder card, which is maybe better shown like this. It just provides a little bit of information about lead prevention. And then there's also the opportunity for the physician to circle what comes next in the patient's care. So either home prevention, a finger prick, a blood draw, early intervention referral, or a home lead investigation. And then on the back, we talk about the possible outcomes of a high lead level. And then on this side here, there's a little Q&A section about what is lead, what should I do, where can I find it, and how do I protect my child? So those are kind of the visual tools that will be in your binder toolkit. But the majority of the time will be spent on that lead action plan. And then just kind of referencing resources as you see fit.
I did just want to point out too, on that best practices sheet, we did build out pieces for follow-up. I can't remember what I did this morning, so I forgot that we did that, but it is there. So feel free to use that best practices sheet for any area that a practice might want to work on.
Okay, just a few more things. I know we're approaching 8:30. I will try my best to get you out of here soon.
And
So
if
have you
there,
just wanted, oh, sorry, go ahead.
I was just gonna say, since we're reaching time, if there's anyone who wants to do a little practice run, you can just reach out to me and I'm happy to get on a quick call with you and do that.
Liz, were you gonna say something?
Sure, I was just gonna add, I'm sure you're gonna cover it, but just the practice folders that are gonna be delivered to as well, okay.
Yes. I'm going to share my screen again with all of our resources. So we have the ones that we ran through today, but this is also another way to, my apologies, to look at them. So this here is that data form that they're going to fill out. And then if you've never had a chance to take a peek at our toolkit, it's really a great resource. It's a comprehensive lead education, almost like a 1-hour webinar, but in toolkit form. And you can really punt people here if they have more specific questions, and then want to kind of delve into the literature as well. And then we also have our physician resource guide, which is 11 pages of clinically specific lead intervention. And I will let you all scroll through this wonderful information at your own pace. And then you might be wondering, Sahabi, you've shared 1,000,001 links. How am I going to keep track of them all? We've made a lead hub page. So if you go to lead.ohioaap.org, you can find some basic information about our Lead-Free Ohio initiatives. And then you'll also find our resources here. So we have that RAC card in English and Spanish, our Thanks for Keeping Me Lead-Free board book, extra copies of that lead action plan. And then this link will take you to our family resource page, which essentially has these same resources just available for families. And then if you click on our forms tab, we have all of the data collection that we've developed thus far. And then this one is the one that I'll call your attention to. This is your reflection form. And it says for trainers only. So we're hoping that you guys are the only people who are going to click on this link, but I'll just open it up. It's just a few questions about how the training went and if you need any more resources. And then the last thing I will call your attention to on my screen is our Ohio AAP DEI toolkit. We just want to make sure that as you're going forward and representing the Ohio AAP and the Lead-Free Ohio program, that you're giving consideration to inclusion, equity, and other awareness of other people that live in different cultures, knowing that lead affects children of all demographics. And I will share this in our slides as well. And then you can just peruse through it at your own pace. There's a general checklist, some common terms if you want to review and refresh. And then if you have any feedback on it, Liz Dawson, who's on the call right now, would love to hear your thoughts on it. So that's just a little pitch on the DEI toolkit. Would love to have you take a look before you head out into your various areas of Ohio. And then lastly, we have our practice folders. So when you receive your lead binders, you will also receive a folder for each practice you're going to, plus one extra in case something happens. And it's just a plain folder. And inside they also have their own table of contents. And then they have the same QR code reference sheet so they can refer to our resources. And then they have our best practices list. And they will also get one copy of our RAC card and one copy of the appointment reminder card. If there is room in the boxes for the appointment reminder cards, they will receive a stack as well for you to distribute to the practices that you're going out to, so that way they can start implementing that new resource right away. And I know that was a lot, and I think I covered it all, but if I missed anything, please, Dr. Davidson or Dr. Takor, let me know, and I'm happy to answer any questions on those resources.
Suhavia, I would like to share, first of all, my deep appreciation for all of the work that the Ohio chapter staff has put into this project. What you just presented was really a big culmination of a lot of effort, and Suhavi and Mark and Liz deserve a lot of credit for keeping all that organized. Rupa has been instrumental in a lot of the content, but I do want to make sure that I also recognize Nick Newman's contribution to this work. He is not able to be with us right now, but his name's on the website, and he really did provide a large amount of input over the last 5 years into that provider toolkit. So I'd like to just recognize Nick in that appreciation. I'm greatly appreciative that each of you have been invested in this work, that you're willing to spend Tuesday night an hour and a half to get your bearings on what exactly we're talking about. How we're planning on approaching 50, what did you say, 53 or 55? The number just keeps increasing. Practices throughout the state of Ohio. It's phenomenal in the number of practices that we're going to get a chance to interact with. So I'm greatly appreciative of your time, of your effort, and your expertise in working with these practices. So thank you.
Could not have said it better myself. Ditto.
Before we
are there any other? Go ahead, Subhav.
Before we hop off for the night, I think we were going to say the exact same thing. Do we have any other questions? Okay. Feel free to email any question at all. This is a pilot program. If you have not heard, this is our first time ever putting something like this together. So we're figuring it out as well as you. So please don't hesitate to reach out with any questions or comments or concerns. I will be in touch tomorrow with everything that we covered today, slide decks, binders, resources, and in the meantime, like I said, feel free to email with any questions. Thank you so much for your time this evening, and I look forward to this practice coaching program with you all.
Yep. I'll just echo what Joel said. Thank you to our amazing staff, and thanks to all of you for sort of going on this ride with us with the chapter and really trying to sort of improve outcomes in the state. So thank you all.
Thank you.
Right.
Have a good night.
Night.